For example, he played a key role in the discovery of two groundbreaking cardiovascular drugs. He pioneered the use of telemetry in research, significantly advancing methods for measuring physiological parameters in conscious, unrestrained animals. He was the permanent 3R's representative for Oncology Basel during his time in Novartis, and we're very honored to have you here with us today.
Thanks a lot. Thanks for the introduction, and thanks for the invitation to present our data, which we have collected in terms of oncology and especially the metastasis. So the topic of today is obviously oncology and the cancer, and I think it's quite clear to everybody that it's definitely a growing burden in nowadays. You see there are 20 million new cancer cases, and at the end of the day, it's really the metastases which are the leading cause of death. And there is a need to develop a simple method to track tumor cells and metastasis in our preclinical models. So the status of the art, which you might know, is quite simple. Mostly what you do, you take a tumor cells, you engineer it with such a way that you are introducing and transfect the luciferase gene. Then you have to inject in the animal the substrate, luciferin. You wait for 15 minutes normally, and then you just put the animal under the camera, as you can see, and then you have a nice picture. As you can see in the middle, everything is fine. It doesn't take long. It takes 1 minute to take such a picture, and you can put this in a publication. Everybody is happy, and you can follow the tumor growth over time. On the bottom, you can see the biochemical reaction which is used for that. And basically what you need is that you need a living cell, which is in this case, this is the reason why you have the ATP. You need the substrate, the luciferin, and then you have, as a result of the biochemical reaction, you have the production of photons, light, and you need oxygen also. So this is done, as you can see, in anesthetized animals. Why? Because we are using mostly isofuran. It's a high lipid solubility, is rapidly absorbed, and you have a good muscle relaxation, and the animal recovers really fast when you stop the anesthesia. However, you have to keep in mind, we have a tumor sitting on a host, which is the animal, in this case the mice, and we know that anesthesia will affect everything you can think about. So you just have to name it. And mostly what I have listed here is that you have a respiratory depression, you have hypotension and hypothermia really rapidly going on. I will show you some data later on. So you have a decreased rate of oxygen consumption in tumor tissue, which are anyway in an acidosis situation. And then you have also much less blood flushing through the tumor, which will obviously affect the biochemical reaction. And you have, mostly in all tumors which are sitting on the back of our mice, you have a high hypoxic fraction anyway, so you are just fostering this more. And then I asked the question to my colleagues, why are you using anesthesia to do your picture? And they always ask me, what a silly question. We don't want the animal to move around under the camera, so we have to immobilize them. And then I was thinking, but do we really need anesthesia to immobilize an animal? I think when we take blood, we just put it in a tube, isn't it? We did it, and then the animal is out. So why not using the same approach? Nothing to discover here. Everything is available for the same purpose. So here we build some in-house restrainer, very simple, plexiglass. Put the animal in, put under the camera, press the button, and you have your picture. And you can see here on the left, when you measure blood pressure via radiotelemetry, so a remote monitoring system, you can see that in the normal situation, which is from 0 to 10, this is the blood pressure, then you give isofuran 4%, and you can appreciate how fast, in 5 minutes, we have from 120, we go to 90, then we switch to 2.5% to keep anesthesia, and blood pressure is just going down, going down, going down. And the little square here, this is normally the time when we do the measurement, pressing the button. So we have basically here 33% decrease in blood pressure due to anesthesia. And this is not a surprise. This is just normal physiology, but nobody cares because it's easy to press the button, isn't it? So does it really play a role? And I think what you can see on the right is really astonishing. I was amazed when I saw that. So we have here a picture of a tumor which is sitting under the skin in a conscious situation. Then we just switch off the isofuran, and we look what happened. After 5 minutes, 70% of the signal is gone. So we are consciously flushing down or switching down everything which is driving the reaction. What a silly idea. But okay, now we have the proof that it makes a difference, isn't it? And what is really interesting is that when we follow now the dynamic effect of that, so you see this is now the bioluminescence. One is when they are conscious, then we start to put them down with isophone 4% to see we have now the 70% reduced. And then we are switching your isophone to 2.5%, and then it goes up. So at the end of the day, just, I don't want to be provocative, but tell me what you want. I can do it for you. I just have to tune my isophone, and the signal will go up and down. Sometimes a little bit tricky, isn't it, if you want to reproduce things. In addition, what is really important, we are interested in a time increase in tumor growth. So we want to image the same animal several times. And what you do, as you have seen, we have mostly 6 animals under the camera. And you are tuning your isophone so that any animal is sleeping. So all the animals will get another percentage from one day to another. No surprise that you have big variability. It's just done in, at least I would say, a big part is done to this deepness of anesthesia, which you cannot control. There's no way. So just to show you that this is not just a one event in one tumor, which you have seen on the left, this was a melanoma, but you see we have a colorectal 64% decrease, and then on the right, the multiple myeloma, we have 67% decrease. So it was really reproducible from one tumor type to another that we have around this 60 to 70% decrease in signal, and this is really pivotal. And I think, why should we do that? So I want to talk today about metastasis. So these are primary tumors, but look on mets here. So on the left, you have now the spinal cord metastasis, conscious versus anesthetized, quite clear. We have a big decrease. The bone mets in the middle, conscious, anesthetized. But what is interesting to see is that the spleen is not getting down. It's more or less stable, or even with a tendency to go up. But look on the right, in the brain, the signal in the anesthetized situation is going up. And this is just normal physiology. If you anesthetize an animal, all the blood will flash to the key organs, which is basically the stomach, the heart, and the brain, to keep the animal alive. So what you see here is just nicely physiology, which you can follow with bioluminescence. And just to make it even a little more beautiful, so this is again the time frame. So you see 0, the animal is conscious, then we start to anesthetize the animal, and this is now the signal of this glioblastoma tumor in the brain of the mice. It goes up 2.5%, it stays there, but as soon as we stop isophone and the animal starts to recover, you can see the signal is going down again. So that was really, really nice to see. And as a conclusion on this part, I would say that really there is no need for isophone. Just take an animal in a restrainer, which everybody has. At the end of the day, a very cheap way, just take a falcon tube, very easy. You put a mice on the table and a falcon tube. I can guarantee that in 30 seconds, the animal is in the tube, because this is a way to be hidden, to be safe. You don't have to force them. They will just go. So why not using this natural behavior for your readout? And as I just say, as you can clearly see that it has a big impact. So just an easy ID, very cheap, nothing else. So let's go now to the dissemination metastatic model, which, as I say, is a very, let's say, difficult model to establish. First of all, if you have a tumor which starts to grow subcutaneously, it will never metastasize. So that's already a big caveat for the translatability of these models to the human situation. So what we have to do here is that we have to inject the tumor cell, the contracted one, in the tail vein of the animal intravenously, and then the tumor cell will disseminate around the body and will then, with time, colonize the different organs. But you see, it takes basically 21 days that you start to see something, and then it increases very rapidly in the next 30 days. Here in this case, you see, you have mets in the liver, in the kidney, and in the ovary duct, and also sometimes in the bone. So that's the standard of the art. But one of the big problems which we have here is that it's very difficult to follow the same animal over time because we are limited from our license in terms of the number of anesthesia we can proceed in the same animal. So you will have to select at which time point you are going to do a measurement. Nobody will tell you which is the best time point, so you have to decide. Mostly you do it once a week, but is it really optimal? No idea. But that's the way to do. So there is clearly a need to get a more simpler method where we could follow the bioluminescence and tumor growth in a much more accurate way. And one possibility is to use another bioluminescence, which is based not on the firefly luciferin, but on the Ghostia princeps. The nice part of this GLUC is that it has really the highest reported activity for the lucifer. It's basically 100 to 1,000 times more lightful, if you want, compared to the firefly. But what you can see, it's something which is very rapid, and then it goes down. The firefly stays for 15 minutes. Here it's basically, I would say, between 30 seconds and 1 minute, where you have to catch your signal. So it's a little bit different from this point of view. But the nice thing is that you can just do this from 20 microliter of blood, which you have taken from your mice. You take the blood, you put it in a 96 well plate, you put it in the fridge, you can forget it for 6 months, doesn't matter. After a while, you take it out, you put it in this reader, and you have your signal. It's very simple, and you don't have to stress the animal, and you can do continuously the measurement in a very simple way. Obviously, you will have to validate this, and this is on this slide. So on the x-axis, I have from the same tumor. So the beauty of these cells is that we're able to double transfect them with the GLUC and the firefly luciferin, so we can follow the same signal at the same time. So on the x-axis, you have the light intensity from the GLUC, on the y-axis, the firefly, and you can definitely appreciate that we have a really good correlation between both at different time points. But what is really important to mention here is that you see the dynamic range of the GLUC is basically 5 logs. If you compare this to the firefly, it's only 3 logs, so you have a much bigger dynamic range to follow. But most importantly, and this is the background, you see, with the bioluminescence, it's basically 1/10⁶, where you can start to do a measurement. With the GLUC, it's 1/10⁵. So it's basically 3 logs less, and then you can start to have an accurate measurement of your bioluminescence. The beauty, in addition, with the blood from the tail is that it will reflect all the metastases in the body, independent where they are. They will produce the signal, which is not the case with the FLUC, where you need, as I say, 10⁶ in order to see something under your camera. So that's another big advantage. So let's see what happens over time. So here you can see when we inject the tumor cells via the tail vein in the animal, already after 4 days, we can start to see a signal, and then you have a very nice logarithmic growth over time. And when we do then some bioluminescence at a selected time point, and this is now after 14 days, you can clearly see that we have already 2 logs over baseline with the GLUC. But if you look now under the camera, there's absolutely no signal, 0. So we would say, okay, we cannot start the experiment. We have to wait until we see something. But based on the GLUC, we are already 2 logs over the background. And it's only at day 28 where we start to see some bioluminescent signal, but you see, not in all the animals. So it's very different. But in terms of GLUC, we are already on a very, very high level. So that's, I would say, that was also very impressive. So it's very, in terms of the 3 years, what is also very important here is that we can start to treat the animals much earlier, meaning that we don't need a big, let's say, metastasis load in the animal, which certainly impacts their well-being before we start the experiment. And we are pretty sure that we are only selecting animals where the tumors, the metastases are growing. You can see here on the left, we can follow from day 8 to day 14 the normal baseline, exponential growth, and then we can start to treat with a compound X, which you can see here. You see that the control starts to grow in a logarithmic way, but the treated animal, we have basically 95% decrease in the metastatic burden, and then after a while, obviously because it's only a single dose, the tumor, the met starts to regrow with the same speed as the control. What is important to notice here, and this is also a big part for the 3 years, is that how can you translate, let's say, a refinement to a reduction? And one good way is just the variability. So if you look here on the coefficient of variability, when we measure the animal in with the firefly versus with the G-Luc, we have basically a 61% reduction in the variability, meaning that we can reduce the number of animals per group and having at least the same, if not a better statistical power at the end of the day. So again, here it very nicely reflects how refinement can also induce a reduction. And just to come back to this, I think with this method now, we don't need the isoflurane. Just at the end, for the beauty to show how the metastases are distributed in which organ, which you cannot see obviously when you take blood, but this is now one isoflurane. And if we compare to the previously one, we have 90% reduction. So much better. And coming back to what Fabienne was saying at the beginning, this is important also for the staff. I can tell you that if you have somebody which is doing a one-day bioluminescence measurement with isoflurane, they just come to you at the end of the day and then say, okay, tomorrow somebody else. I don't want to do it anymore. I have headaches. I don't feel well. And if you can tell them, look, forget isoflurane. We don't need it. And we have better data. So it's a win-win. And as I say, happy staff makes happy animals. And I absolutely in favor of that. So I just want to conclude here just by showing you that when we use these different approaches, we have now a much better outcome, much better quality of data with less bias induced by anesthesia. And I think at the end of the day, everybody profits from that. And also very important, the coefficient of variability is really heavily decreased, which can definitely then induce a reduction in number of animals. So with that, I will stop and happy to take any kind of questions.
Yeah, thank you so much for such a wonderful talk. So I have a question on the G-Luc.
Yeah.
We have worked with this luciferase, and I don't remember now if we had a mutant or not, but okay, as far as I remember, it was a secreted.
Yeah, exactly. This is a secreted one. Yes.
This is a secreted,
yeah,
right?
Exactly, yeah.
So in blood, what you measure is whatever it was secreted to the systemic.
Absolutely,
right?
absolutely.
Okay,
that's
good.
right. Yeah.
And how do you correlate that with metastasis?
Well, I think at the end of the day, when we inject the animals with the transfected cells, they will disseminate somewhere and they will create a kind of metastasis. It's artificial. Obviously, it's not the same situation as in humans, but it reflects more or less. That's the best we can do at the present time, unfortunately. Another way would be to inject directly the tumor cells in the organs, which needs surgery, and which is also a kind of biased. It's not the normal way metastases are disseminating. So it's just, as I say, if you take the blood, it's just a net result of all the mets somewhere. And the reason why we take a picture at the end of the day is just to show to people, look, this is where the mets were, or not, if the compound was acting nicely. So that's the reason why. But you're absolutely right. It's a secreted one, so you cannot disseminate or discriminate from where it's coming, but it's from the body.
Thank you.
So thank you for the presentation. I was wondering just if you have measured by any mean the oxygen level using when you use isoflurane anesthesia. Does it drop along with the blood pressure or not?
Yeah, I think we have done this, but not in a routine way. What we have also done is also we are using some casts, which will then show you how many patent vessels are inside the tumor. And the tumor is really chaotic. You know, the vascularization is absolutely abnormal. And you could very nicely see that there are a lot of hypoxic places. And if you stop the blood flow, or if you reduce the blood flow significantly, you can expect that there are many places in the tumor which are not vascularized and which are definitely where the substrate is not getting in. And then no surprise that you have 70% decrease in signal because there is no substrate there. That's all.
Thank you very much for this really inspiring talk. I loved the criticism of the methodology that you presented, and but my question is a little bit directing into the general realm. But your criticism now on the model, the methodological criticism, could be of course carried further, because this was the mouse model for human cancer. Do you think these epistemological questions could take up more weight in the future to discuss about models in research? Did I put my question okay?
Yeah, I see from where you are coming. But I think we all know here is that the failure rate of all the compounds from pharmaceutical companies getting to the clinic is around 80%. Still, nowadays, 80%. And I'm pretty sure that all my colleagues, we will put 3 hands in the fire if we can for our compound. We are really convinced that this is a good compound. It goes to the clinic, it fails. So the reason is that sometimes there are tox issues which you cannot see up front. But my credo is that it's definitely linked to the models which we are using. We are all aware that we are only using models. It will never be the situation we are facing in the clinic. Cancer is a very special one because each tumor in each patient is different. So how can you predict this? It's very difficult. But my credo is that if you decide, because there is no choice, to use a model to see if your compound works, please try to eliminate as many biases as you can. And one I have shown you here is anesthesia, which is a very simple one and which is at the end of the day not needed. That's the key point, isn't it? I think you are putting yourself in a really bad situation and you don't have to. So just try to think, and as we discussed yesterday, very often, especially in oncology, this was my experience, is that the oncologist forgets that the tumor is sitting on a host. And this host is going to be pivotal for your tumor. It's not just here something which is separated. So if the physiology of the animal is affected, it will affect the tumor, no doubt. And so that's something to put in your equation. Sometimes it doesn't make it easier, but to be honest, I think that's something which we cannot omit, definitely not.
All right. Thank you very much for the talk. I'm really fascinated by the points that you have discussed, and especially on the restrainer that you use for BLI, because I would really like to use it in my project. So I'm wondering, like, is there any special design inside this restrainer, or how long would it be? Is there a time limit that the mice would eventually move during the measurement? And also, I have a second question, like for the G-look, and also, if it's such a nice signal and for the recording, and so why is it not more popular than the normal?
I think one of the reasons is that that's the reason why we do these kind of presentations, just that people are aware. Because it's in the literature since at least 5 years, so it's not something new from yesterday, but it's not going through the community, and that's something which we have faced very often. If you have a traditional way of doing things, people are really reluctant to change until you can really show them, look, that's different. And then you cannot just close your eyes. You shouldn't, isn't it? But you're right. So coming back to your first part, to take the pictures from the animals, it takes normally between 1 and 2 minutes. And between 1 and 2 minutes, the animals are really quiet. You can have some crazy ones, which starts to rotate. So with the design we have used, you can just compress them a little bit more so that they cannot move. For 1 minute, it's fine. Obviously, it will induce stress in the animals, no doubt. But the beauty is that if you induce stress in the animal for this really short time, blood pressure will go up. So if blood pressure goes up, your signal should normally go up as well. So if I have a good compound, I prefer to give the compound a hard time to show efficacy than the other way around. If you have anesthesia, the signal goes down. It's not difficult for a compound to lower this. So you know what I mean. So that's definitely something which we have seen, but we have not faced this kind of issue that the animals are rotating all the time and say, what shall I do now? You see, so yeah, and it's very cheap. I can tell you, that doesn't need a lot.
Get the design would be nice.
Yeah.
Well, then, thank you so much for these
You're
great
welcome.
insights.
You're welcome.